So I'm preparing it for go onto YouTube. So I'm preparing it for go onto YouTube. Okay, guys. So we are on live on the YouTube, and a very good afternoon, good evening to everyone. And today we are going to do something called COVID rounds and try to discuss some of the issues that has been faced by people. So we are on live on the YouTube. Okay, it's exactly need to 1 second. Very good afternoon. So here we are going to discuss about some of the commonly faced issue in the intensive care units, and we have with us Dr. Dheeraj L, Tejashwini from Australia, Dheeraj from UK, Dr. Mohan from India, and we also have Anil Kumar from India and Dilip Singh Parmar. I was going to call DSP as well, joining us. So what we plan to do is that a lot of questions or queries have been posed to various people. We will actually just take them. So these are actually cases which the people wanted to discuss, and we can actually then also discuss about just how things can be managed in a better way. So I will hand over to Dheeraj, and he will start the proceedings. And if you get any comments, I will actually pass on to the team, and we can actually take questions. Over to you, Dheeraj.
Okay, thanks, Shiv. I think after yesterday's post in the Anaesthetist, we were discussing on what was the best way of helping some of our junior colleagues who are finding it difficult to ask questions, or they have been having to deal with this scenario. So we just thought we'll use our combined experience and come up with an answer. So I think there have been a few questions asked by people. Some people have asked that question privately just because they're worried that our group is very vast, isn't it? It has got maybe so many members from the same hospital. Sometimes they just don't want to step on toes. So we are quite happy to take anonymous questions too and discuss them as long as there is a discussion to be done on these cases. So I'm going to start with a couple of questions which have been asked. I'll open it to the floor. I'll get their opinions, and then I can get some of the cases which have been dealt with our colleagues in India, Anshul, Dilip, and Mohan, and then we can discuss some of the cases which they have had too. So the first question for the day which I had was, my patient is on CPAP for the last 7 days, still requiring an FiO2 of greater than 70%. The respiratory rate of the patient is above 40. I am scared of ventilating her, and is there anything else I can do? So if there's anyone else who wants to go first, DSP, do you want to go first? You're on mute, is it?
Dilip, can you unmute yourself?
ये क्या बोले मेरी समझ में ही नहीं आया.
I don't understand. You need to give him the scenario once again.
Okay. So the scenario is that the patient has been on CPAP for 7 days. Our patient still has an FiO2 of greater than 70%. The patient's respiratory rate now is 40. That doctor is scared of ventilating her and is asking, is there anything else they can do for the patient?
Okay. Sir, मैं इस patient को prone ventilation करूँगा.
Dilip, can we speak in English, please?
हाँ. Prone ventilation for 18 hours for this patient, sir. Then high dose of steroid. And yes, sir. But nothing else. What else you want expecting?
Okay, so I was gonna start this question with the way I was gonna answer it for this patient was, you have to be very careful of keeping someone on CPAP. Now, I understand the general apprehension for people with COVID is not to try ventilating them, because some of the worst outcomes which we have had was after intubation and ventilation. So our experience from the UK was initially when we actually had the first wave, we had quite a lot of reports coming from Italy saying that go ahead and intubate them early. Now that is because the healthcare system in Italy is completely different. There, the anesthetist just goes and intubate the patient, and then it's the intensivist who takes care of them. Whereas in the UK, it was we quite a lot of us who are intensivists are anesthetists too. So what was happening at that time was we found that once we rushed into intubation, quite a lot of patients didn't do well. And one of the reasons for doing that was basically because this was a same disease which was presenting with two different kinds of pathology. One, we had someone who had what is called as low compliance, and the other one was people who had very high compliance, and hence this became a problem. So the general postulation now is that if you actually keep a patient on spontaneous ventilation for a long time, the patients with COVID have a very exaggerated respiratory drive. And when they have an exaggerated respiratory drive, they tend to what is called get what is called as PCL, which is, it's patient spontaneously breathing induced lung injury. This occurs because the patients are breathing at a very high rate and high tidal volumes. So this itself causes lung injury. And hence the reason in this case, if your patient is on CPAP for a very long time and is showing signs that the patient is tiring, unfortunately, we do not have any other option rather than going and intubating and ventilating them. So in this patient, if she's been on CPAP for 7 days, you're finding that the FiO2 is persistently rising and the patient's respiratory rate is rising. The best course of action in this patient at this point would be to actually intubate and ventilate. And how we ventilate the patient is a completely different conversation. Dr. Mohan, do you want to come in? You're muted.
I agree with you. If the patient is not doing well with the trial of non-invasive ventilation, we should go ahead and intubate them unless they're showing an improvement, because they will end up with a secondary bacterial pneumonia, less compliance, and worsening of the consolidation, and it will be hard to ventilate them later. So NIV usually in 2 to 3 days, we should be seeing a decrease in the oxygen.
That's right. I think what is very important to understand here is that initially the problem occurs because of oxygenation. There is a tendency of a lot of people to go for CPAP rather than go for high frequency nasal oxygen. There's been discussions worldwide on what is better. I mean, generally the consensus is because of the way the pathology is, the initial pathology is a problem of vasculopathy. It is a problem because there is nothing wrong with the lungs, but initially is a vascular problem. And that's the reason providing oxygen at that point is very, very important than providing things like CPAP or NIV. And once the patient, starts hyperventilating, goes into this exaggerated drive, then we have seen a lot of times that this L phenotype, which is there, which is the patients coming with high compliance, then go to an ARDS pattern, which is the H type. Okay, and that disease then behaves like ARDS. Once you have come to that phase of ventilation, then you need to ventilate the patient like you would do for any ARDS patient. So of course, as Dilip rightly mentioned, at this point is one where we go for high dose steroids. This point is the one where we go for other methods, like if you're using TOSI in your institute, go for TOSI. Prone position ventilation is absolutely vital in these cases. Previously, after the ProSeva study came, when the ProSeva study came, it was one of the studies which actually showed mortality benefit in ARDS patient if you prone the patients. But their protocol at that time was proning patients for 16 hours continuously and then turning them over and doing it twice. One of the things which COVID taught us is that sometimes you need to prone these patients 5 times, 6 times, 7 times, because the amount of time you have to ventilate these patients is completely different than what you would do for conventional diseases, which we have looked at. And we have done it for a lot of patients. And I know in many places they have had proning teams. We had our orthopedic surgeons, all those people who actually, because at that time there was nothing much going on from the elective surgery point of view, they were forming teams. These necessarily do not have to be doctors. And they were coming and they were proning these patients. But of course, you have to have training for them, because the worst thing you could do is someone on a oxygenation of 70% dislodging the tube when the patient is prone. That is going to cause tremendous harm. So in answer to that question, I mean, my opinion would be that you have given CPAP for some time, you have seen it's not working, your oxygen requirements are still very high, your patient's starting to tire now. This would be the point of going ahead and intubating the patient. And what ventilatory strategies you use after that is something which we can discuss on in further questions. But just from the point of answering that question, I think this is what I would do. Any other one? Anyone else with any other opinions?
Tej?
Sir,
Tejas?
Anil here.
Anil, yeah.
Few of them are question. I mean, they have questions on how to initiate NIV. If the senior members can pitch in, it will be helpful. It sounds a very basic request, but I have had a few queries of how to initiate NIV.
Okay, Teju, you want to go there?
Yes, sir. So first thing is, I think in the scenario that you gave, I would completely agree with intubation and ventilation straight away, because 70% FiO2 to maintain a PaO2 of 60 is quite a bit of oxygen requirement with a respiratory rate of 40. In someone who has been on CPAP for a week, she will eventually tire out, and the best thing would be to go ahead with intubation and then proning depending on the oxygenation improvement post intubation. I would ventilate her based on the ARTSNet protocol with high tidal volume and low PEEP, like how we've been doing for any other ARDS. Apart from the fact, like you mentioned, going ahead with a longer time for proning. So with regards to initiation of NIV, so the way I would usually start is I usually prefer a CPAP mode to begin with, if they're not CO2 retainers and if they're able to tolerate. My points, how I usually decide on when and how to initiate NIV is whether the patient is awake enough to tolerate and understand the use of NIV mask. And I usually prefer a whole face mask with usually we have an option to use transparent whole face mask, which is what I normally use. And I don't sedate patients when they are requiring non-invasive ventilation. I usually start with, depending on the oxygen requirement, I usually start with the bare minimum settings of like maybe 6 of PEEP and inspiratory pressures of 12. But if the patient has CO2 retention, they usually somehow seem to tolerate BiPAP better. Even in patients with APO, I prefer BiPAP mode to over CPAP mode. So whatever is more comfortable for the patient is what I normally use. And in my experience, which is very limited, I must admit, because we only saw COVID. We had around 20 patients in the first wave. At that time, the guidelines, that was in last March. At that time, the guidelines was that NIV was an aerosol generating thing, whereas nasal high flow was not. So we did not use non-invasive for COVID patients, unfortunately. But for regular non-invasive ventilation, I usually start with a low dose settings, try CPAP, and then change over to BiPAP depending on the patient compliance. And I think the most important thing with initiating non-invasive is to explain the procedure to the patient and ensure that they are with you when you are doing it. And if at all the patient is extremely agitated, but you know that they're going to improve, like APO patients, you know they're going to improve in some time, then we usually use dexmedetomidine to help with the awake sedation in some of the patients, low dose dexmed. Either it works or it doesn't, but sometimes we use that. Atypical antipsychotics also sometimes, if they're really agitated and delirious, NIV does cause a lot of delirium, so we use that as well. But I usually start with a low setting of PEEP of around 5 to 6 and pressure support of 10 to 12. And even if it's BiPAP, I usually go for 6 and 12 IPAP versus EPAP, and then usually set it up. The FiO2 requirement is completely based on the PaO2s on the blood gases, and we titrate the FiO2 requirement to PaO2s.
Thank you, Teju. That was a very helpful answer. The only thing which I think you mistakenly mentioned was high tidal volumes in ARDS. That's not, it's low tidal volume and high PEEP, but it doesn't
absolutely,
matter.
sir. Low tidal volume, high PEEP, and high respiratory rate.
Yeah. Yeah, I mean, the thing is that what is very important to understand, and I always keep teaching my juniors this, is that ventilation is a function of CO2. It is not a function of oxygen. The only thing you can improve, if you want to improve someone's oxygen on a ventilator, the only thing you can use is FiO2. Second is you can use PEEP. And the third thing you can use is something like inverse ratio ventilation. Now, for doing any of this, apart from inverse ratio ventilation, you don't necessarily need to intubate and ventilate the patient. So when we intubate and ventilation the patient, in this scenario, we're talking about resting the patient, preventing PCL, and trying to use advanced modes with which we can curtail or which with we can improve oxygenation. Now, the reason I'm saying this is that you could use simpler methods. So if you try with your nasal prongs, oxygen mask, reservoir bag, and we had this problem. We consciously decided in the first way to go towards CPAP. It's not because it was any way superior, but we knew that if we actually took a Bujik neck mask, we'll have to only give 15 liters of oxygen. But if we had to use something like, high frequency nasal oxygen, we would probably end up using 30 to 40 liters of oxygen, and we will run out of oxygen. And it's a scenario which I think a lot of places in India are finding at present. So if you are actually going to start, you have the option of either starting on high frequency nasal oxygen. If that's not available, then probably CPAP or NIV. Now, yeah, CPAP versus NIV, it's always very difficult to explain the patient. A CPAP is not simple. I mean, all of us have tried a CPAP mask somewhere, and we know how bad it is. It's like putting your face out while driving on the motorway and with all that air hitting your face. And sometimes that can be suffocating, so people can't tolerate it. But generally, as a rule, I would say is that try CPAP first. If it doesn't work, NIV is an option. And as Teju likely said, you're just giving a little bit of pressure support. Because remember, when the patients initially come, their compliance is quite good. You will very rarely find a patient whose compliance is bad when they initially come to you. So the lung compliance is very good. So by giving CPAP, by trying to recruit, there's nothing. You will, for a small change in delta P. So if you put up someone on a pressure support of, when you're giving a BiPAP, P high pressure support, whatever you call that thing on a BiPAP, a 10 and 5, that is enough, because you're not worried about patient generating tidal volume. When we use NIV for things like COPD, there we are worried about generating a certain tidal volume because we know the patient's not generating that tidal volume. That's why your pressures have to go high. In this, the patient's tidal volumes will be quite good. You are just supporting with a little bit of PEEP. The problem here is what you got to understand is it's a vasculopathy in the initial stages. Your lung is acting like a massive dead space, isn't it? Because your lungs are okay, it is ventilating, but it's probably a problem with your perfusion. So any ventilatory techniques at that point is not useful. It's only when then the lungs start getting worse, and then you start having problems with your compliance, that then you have to recruit the lungs, then you have to intubate, then you have to try the other modes. So that would be my the way I would say. Anyone else? Mohan, do you have anything to add?
HFNC works well to reduce the secretions, but the main problem, like you said, is the oxygen availability. So now we have almost parked all our HFNC, and we are just trying to use the BiPAP to tide over the crisis.
Okay.
Also, Dheeraj, I think what was seen with the non-invasive ventilation, I think instead of these masks, the helmets have been shown to actually be better than the face mask.
Yeah.
I think you said they use a whole face rather than the partial face mask. I think probably they are well tolerated. Whole face masks are well tolerated, as are the helmet.
Yes, and also with nasal high flows, the biggest advantage was awake proning. The patients could easily prone themselves when they are on nasal high flows when compared to non-invasive masks.
That's true.
Now we are not giving them any choice. Every patient in the hospital has to be prone, whether he likes it or not.
Yeah.
Yeah, I mean, to summarize this, I think if I were given a choice, my option would still be high frequency nasal oxygen proning to these patients. Okay, once they go on oxygen, to start them straight away on steroids. Try to see how they do. If you find that your patient's tiring, the respiratory rate is increasing, your CO2 is starting to go up, then you have hit a point where you're not going to be very successful in whatever you're going to do. There's a role for other agents like pulmonary vasodilators. We'll come to that at that point. I would then, if you find that you don't have high frequency nasal, not high frequency, If you don't have high flow nasal oxygen like Optiflow, that is a point where CPAP is a good alternative. Put them on CPAP or NIV. Don't go too much with the PEEP because they have nothing to be recruited. The lungs are good. Okay, so don't go on escalating PEEP like to 10, 15 things like that. It doesn't work in this situation. If anything, you're going to blow a lot of air into the stomach and cause even more problem with ventilation. With NIV, what you got to remember is that this pushes air not just into a nostril, but into your face and your mouth. Yeah. So if you are on higher pressures, it goes into your esophagus. It starts, inflating your stomach. Once that happens, you get stenting of your diaphragm. Your airway resistance increases. So it becomes a very vicious cycle. So you have to be very, very conscious that in a patient who is not really cooperating, NIV can actually worsen your ventilation rather than improve that. So that's a point you need to keep in your mind. Anyone else have any other things to add here?
Dr. Teju had a good point about some sort of sedation for these patients. It actually works. We are using clonidine in our institute, and we have had decent results with patients on NIV. Only in few patients there was requirement of antipsychotics like olanzapine. Otherwise, clonidine does the job well.
Yeah. I think that's right. Dexmed also, as you said, Dexmed actually helps in tolerating these patients absolutely fantastically. With Dexmed, sometimes you can have intubated patients with tube in their throat and they're still cooperative. So it is quite a good way of getting patients to cooperate. So I completely agree, Anil, and it's a very good point. I think if patients are not tolerating NIV, you might have to use a little bit of sedation, and there's nothing wrong in doing that. We sedate patients left, right, and centers. Most of us are anesthetists, so there's nothing in giving a small amount of sedation to maintain oxygenation in these patients.
These patients have a very high respiratory drive, so with the sedation, we don't see any effect that they are too drowsy. It's only that they get calm. And one more reason to choose clonidine is its ease of administration. Just put it in the mouth. And we are having huge manpower issues also. So the oral tablets are helping a lot. We're trying to keep it very simple. Use the proning, and 80 to 90% of our drug chart is just simple oral medications.
Okay. Yeah. Interesting. Yeah.
Yeah, it's just absorption is a problem with the sick patients. That's the only thing which we're worried about. What's the sort of for the purpose of the audience? What sort of doses do you use, and what's your current practice there, Dr. Mohan?
Clonidine.
7500, yeah.
Clonidine, we're using 100 TID or QID.
Okay, fine. That seems to be a good dose.
What dose of olanzapine do you use?
Usually, the first day 10 BD and 10 OD later. Okay. If they're not settling with this, you can go for higher doses, but such a patient will not progress in a right direction. It's better to tube them and properly sedate and ventilate them.
Yeah.
Okay.
So the doses we use is 5 milligrams BD or 5 milligrams OD. We found that even that dose is quite sufficient, because increasing the dose is not going to help you in any way. If anything, it will make the patient more agitated. If you're actually not getting any joy with that and the patient is still delirious and is showing signs of hyperdelirium, then that is when we think about whether we need to add haloperidol or any other agent or convert to haloperidol.
I was actually going to ask that. Would you actually use haloperidol in this case? Okay. Yeah. So I actually, now this morning there was actually another personal query. So this is about one of our anesthetic juniors, and I think his dad is actually admitted. Okay. And so he's only on high flow nasal oxygen, and he seems to be doing okay, still maintaining. But his thing is that he actually gets very anxious at times. Right. And at that time, he starts hyperventilating. He actually drops his saturation. He gets kind of agitated as well. So what would you suggest for him?
Teju, you want to come in?
I think the biggest factor in anxiety is to relieve anxiety in any of these patients is to ensure that family has an interaction with them and taking care of the patient interaction with them. The second thing is some of these patients would be withdrawing from alcohol. In those patients, benzodiazepines have been used, and they have, like last week, we had a 89-year-old patient who had to be put on non-invasive. We didn't want to tube her, and she was extremely anxious, and she would just pull out the non-invasive mask, and then we realized she was actually withdrawing from alcohol. She would have a glass of wine every evening before she goes to bed, and every time at 9 o'clock she would just become extremely anxious. All she needed was 5 of Dias, and she settled down. So I know benzos do worsen delirium in ICU, but this is one spectrum of people who are withdrawing from alcohol who benefit from benzodiazepines. And if they're not able to tolerate at all, then we can use some subcut fentanyl. That is something that we also use, because sometimes pain could be the cause of anxiety as well. So subcut fentanyl usually helps. I don't prefer to give IV fentanyl in somebody who is actually having a low respiratory drive or non-invasive and drowsy with all these medications that we would have given them. So I usually give subcut to check if they respond to that. And in some of these patients, dexmedetomidine has actually allayed anxiety quite significantly. But if it is just anxiety, and if it's not related to anything else, like delirium can also present as anxiety, pain can present as anxiety, increased heart rate, and all of these. So just one modality after the other. I would start with benzos, then go for subcut fentanyl, and then the last resort would be something like haloperidol.
Actually,
Yeah.
Dr. Tej had a very good point of pain. ARDS is mostly congestive pain. Probably that is why clonidine is helping a lot, because it has some amount of analgesic effect. So yeah, pain is also a factor which prevents them from actively proning. So if we take care of the pain as well as the anxiety, which is, taken over by a drug like dexmedetomidine or clonidine, it does help a lot.
What about the effect of oral clonidine on blood pressure? It's probably not as significant as it would be with that. Okay. So 100 milligrams so just recapitulate. You would actually give them 100 milligrams of clonidine.
Micrograms, right?
Micrograms, sorry, micrograms. 100 micrograms of clonidine twice or thrice a day?
Thrice to QDS.
Yeah. 3 to 4 times a day.
I think it's very important to understand the concept of sedation in ITU patients is very simple. Imagine you're in that state. You imagine you're having a mask on your face, which is blowing air continuously. Imagine the air is going into your nose, it goes into your eyes. You're hearing a lot of noise. Okay, you can't sleep, you can't rest. You are lying in the same position, even though there is nothing causing pain. It's just your back sometime which gives way. And then you use an agent like haloperidol, which all it does, it's neurolept. It makes you sit in that position. So now you're in pain, and then you're sitting in that position. Imagine the angst that leads to delirium, that leads to substance. Tej mentioned alcohol, but sometimes nicotine is another substance which people. There are quite a lot of smokers. Nicotine patches can help. So fentanyl patches, nicotine patches. So I always have a very systematic way of doing that. It just start with, what do you think? Look at the physical factors. Is the patient getting sleep? If the patient is sleep deprived, the patient is going to get delirious very, very fast in ITU. What can you do to maintain the sleep pattern? Sometimes we start melatonin at night, and the reason is to ensure that you've got that pattern. Noises in ITU with COVID, without having bed, it's going to be terrible. We can't do our normal practices like keep the voice down, keep the lights out, get the patients to sleep. But what you could do is just make sure your patient is pain-free, your patient has some anxiolytic on board, and make sure that if your patient has not had this or has any other problems like sleep disturbances, there are drugs which you can give to keep the patient asleep and calm. So I think that is the whole concept. And this is just not with this is with anything in ITU patients, whether intubated or ventilated, the whole thing comes around this. Clonidine is a very good agent, but there are a lot of agents which you can use. Dexmed also causes the very same effect. It belongs to the very same class of drug. Benzos, low dose, especially in the elderly, be careful of giving huge doses of benzos. All you might have to use is sometimes a milligram of lorazepam, and that's enough to keep them nicely sedated. You really don't even need to go beyond that. You can give that sublingually. So,
Dilip, what benzodiazepine do you use in your setup? Your mic is off. Can you switch on your mic?
Yes, sir.
What benzodiazepine would you use in your setup in India for anxiety? Say, for example, you have a patient with COVID.
No one is bothered about the anxiety of the patient. No one is worried about what
Yeah,
patient.
they're not worried about now. If you are
No,
worried about, would you not give them sedation?
the treating doctor is not worried about what anxiety, what patient feel in them. They put patient on NIV, but I have seen lots of patients are not comfortable with the NIV. So we are giving dextromed infusion to that patient.
How much
Dextromed is
dextromethorphan infusion you are using?
so 200 microgram in 50 ml NS at the rate of 3 to 5 ml per hour.
Okay, in 50 mLs.
Yes, sir. And I never use opioid in a NIV patient.
Yeah. Teju, how often do you use your fentanyl, subcut fentanyl, and how much do you use?
So we very rarely, as I said, it is the last option.
Okay.
The first option is always dexmedetomidine, which we
Okay.
use at a rate of 0.7 to even 1 mic per kg per hour.
Yeah.
And then with fentanyl, the biggest problem with the spectrum of patients that we see is most of them are on fentanyl patches. They're all in their after 70s, and
Yeah.
they're regularly on lorazepam or alprazolam at night. So
Yeah.
that is our biggest problem. That's why we end up using it. And with fentanyl, we usually use 50 to 75 mics subcutaneously.
Yeah. Okay.
And I don't chart regular opioids in any patients on non-invasive. It will only be a one-off dose. It won't be charted as even a PRN or SOS doses. So
Yeah.
it'll be determined only if the patient needs it. Like some of them would be in pain.
Yeah.
Only in those patients who are opioid dependent, I usually use it.
I think the reason why I'm saying this is actually an important thing to understand is that a lot of patients might be actually be intubated unnecessarily if they do not actually look into the fact about anxiety. There are patients I know who actually have said that that'll be the next question coming up in a minute, um, and they might actually get intubated because they keep dropping their saturation, and they think that this patient is actually becoming hypoxic because you're not doing any blood gas in most cases. You're just relying on your pulse oximetry, and you can actually drop saturation. So the next question is about coughing. This is a very common question. Patients actually have dryness, they have cough, and then again, while they're coughing, the saturation they have been maintaining around 93, 94% starts dropping to 84, 85%, and they panic again. So what will be your advice or your management of these patients? How would you actually try to prevent this? This is actually early. We're talking about early COVID, or not even moderate.
Yeah, Anil, do you want to go?
Yeah. Your mic is off, Anil.
Sorry, sir. Is it about the cough, sir?
Coughing, yeah, coughing is quite common.
Coughing, we don't suppress the cough as such, sir.
Yeah.
We actually encourage them to cough out the secretions.
Okay.
And we in last few weeks, we are trying to get the cultures also sent as soon as they have a good amount of cough, so that we can isolate any organisms if at all present. Yeah, we don't usually suppress the cough, sir.
This might be a patient who's directly at home and you are actually advising them and they're asking you.
At home, sir?
Yeah.
Throat
You said this
lozenges
is,
for comfort.
Mohan?
Some throat lozenges for comfort.
Yeah.
If they're having a dry cough, very irritable, then you can go for a codeine syrup or a dextromethorphan. Usually, most of them have occasional cough, and they're worried that they're coughing, so they may become sick. Reassurance will help them. Mild cough, do nothing. productive cough, again, like Anil said, try not to use cough suppressants unless it's very distressing, continuous cough. Then go for this codeine.
What about nebulizations?
Nebulizations helps.
Yeah.
I mean, if you're able to examine the patient and patient has a wheeze, some of them with nebulizing, the cough does come down.
But you can just nebulize, say, saline. I know saline can be irritant, but what about just say, for example, 2.5 milligrams of salbutamol along with 2.5 mLs of normal saline? Would that help? Because one of the problems, I think, the dry oxygen by nasal routes, which have been used, it causes dryness. The advantage of the high flow nasal oxygenation is that you actually can give humidified oxygen. But if patients are just on nasal oxygen, it will dry out. Teju, yeah, over to you. Yeah.
I think the biggest thing that we noted with my family when they were sick with COVID was humidification. So steam inhalation and staying in the room in a humidified room. I just asked my co-sister to actually boil water and leave that before she goes to bed, leave that in the room. And she said the cough significantly decreased with that. And like someone mentioned, I think Mujib sir mentioned about steam inhalation. So without actually going too much into, too much of steam has also been proven to be injuring the mucosa and stuff. So minimal steam inhalation. And then she also used some honey, which really helped in soothing the mucosa for whatever reason and helped reduce cough. And she also used sipping warm water helped her reduce cough.
Yeah.
So that is one other thing which she suggested.
Okay, yeah, I think that is actually important.
Can I come in, Shiv?
Yeah, Dheeraj.
So I think this is a very tricky question. I mean, I think, once you're intubated, ventilated, it's different that you don't want to avoid, any kind of stuff. You want all the secretions to come in. When you're actually not on it, it's quite. One of the interesting things is that if you actually notice normal viral infections, not related to COVID or anything, one of the reasons patients have difficulty in breathing is airway edema and inflammation of the mucosa. And that is why inhaled steroids at that work. And I think there are a little bit of studies going on at present on inhaled budesonide and in patients who are going to get admitted. And I think if you've got some kind of airway edema and that is causing a distress, because usually you find asthmatics also cough quite a lot. One of the presenting symptoms can be that is because of bronchoconstriction at that point. And the constriction is due to a different reason where you have got airway resistance, which is increased by bronchoconstriction. But here, narrowing of the airway, which is caused by airway edema, could also contribute to that. So I think what's the space? I know a lot of primary care physicians in India have started using budesonide MDIs, and it may be useful in that purposes to actually try that and see if that helps, especially if you're having quite a lot of persistent cough and the patient still has oxygenation, which is quite good. So if your oxygenation is going down, then again, it's a semi-indication of starting steroids anyway, in which case a combination of inhaled steroids initially to help you with that. And if your oxygen saturations are remaining persistently low, then you should probably go on oral dexamethasone anyway. So that would be the way I would look at it.
Yeah, that's true. I think budesonide has been actually used instead of actually giving oral or IV steroids. And some of the studies which are coming out actually are showing that it does actually have a good effect. It just maybe that it's locally absorbed as well. And so I think they are being deposited directly into the mucosa and probably into the lungs as well. So I think reducing your airway edema as well as the effect of the steroids actually helps here. Anything,
Okay,
Anil?
so should I move
raising? Yeah.
Was that?
I thought Anil was raising his hand. No.
No.
Okay.
Okay. So Shiv, should I move on to the next question which I was asked?
Yeah.
Okay. So the second question I was asked was, the patient is on a ventilator now, has an FiO2 of 100%. Patient is on pressure controlled ventilation with a PEEP of 14. On the X-ray, they are seeing a small pneumothorax or pneumomediastinum. And the question was like, can modes like APRV be useful? Any volunteers to take this question? Or I can
So,
take it myself.
I'll just say the question. Basically, the patient is on 100% oxygen, being ventilated. So he's on FiO2 ventilated,
Yeah.
and they have noticed a small. Is it? Did you say
Pneumo-
pneumoperitoneum?
yeah, there's a small
Pneumoperitoneum.
pneumothorax and pneumomediastinum.
Yeah, it's quite been reported quite a lot, isn't it now?
Yeah, we have seen a
Pneumomediastinum.
lot.
Yeah,
We have seen a lot of this.
yeah, pneumomediastinum. That's bad. Yeah.
Yeah. So
So
I mean,
question
I
was,
think it's a
you can use
very,
APRV.
yeah. So it's a very tricky question actually, because at this point, I think yes, it's at the point where, so with COVID, what we found out is that a lot of patients develop pneumomediastin, a lot of patients develop pneumothorax. There is a general theory that the lungs are become quite, the lungs are destroyed to a certain extent because of the COVID virus, and then having barotrauma and volutrauma secondary to ventilation is very, very easy. There have been instances where we have actually seen cavitating lesions occur in the lungs too in COVID, and sometimes they coalesce, form a big pneumothorax. And the problem with them is that instituting chest drains have also not helped in improving, in expanding the lungs. So the 2 points to this question. The first point is, if you have a pneumothorax and a pneumomediastinum, whatever mode of ventilation which you're using, you have to be extremely, extremely careful. You need to put a chest drain in. You have to make sure your lungs are expanded, and you need to keep that chest drain in. You can't just see the lung is expanded and remove the chest drain, because there have been instances where that has been done, and the patient has then went on and developed retention pneumothorax. So whatever the mode of ventilation you use, once you've got a pneumothorax and a chest drain, you've already caused some kind of lung trauma. And then this patient already was on pressure controlled ventilation and had a PEEP of 14. Now, there are two things which I want people to be very careful of. One of the things which we did initially when we went with pressure controlled ventilation was we thought we'll use the ARTS network thing. Yeah. So for the group of patients who had what we call as the L phenotype or high compliance, we were then putting them on low tidal volumes and increasing the PEEP to 14, 16, 18. And what we didn't realize is there is nothing to be recruited. The lungs are good. They are having good compliance. And then that mode of ventilation started creating problems. Okay. APRV, what you have got to realize is there is a difference between pressure controlled ventilation and APRV. And APRV is useful only if your patient is spontaneously breathing. If your patient is not spontaneously breathing, APRV is just your pressure controlled ventilation with an inverse ratio ventilation. We have had to paralyze quite a lot of these patients, sometimes for 48 hours, sometimes for 72 hours, because one, they fight the ventilator quite a lot. Their sedation requirements is quite a lot. And plus there is quite a lot of ventricular dyssynchrony. So quite a lot of patients have to be managed with neuromuscular blockers. So once you use a neuromuscular blocker, then the advantage of APRV is very limited, because then you have to limit the amount of P high which you give. The difference between pressure controlled ventilation and APRV is you can't set some people. There was a question which said, oh, my patient is on pressure controlled ventilation, can I set APRV by decreasing the P low? You can't do that, because the reason for that is, if you're using SIMV or pressure controlled ventilation on the higher PEEP or P high, you cannot make any attempts on that. You cannot breathe on that. Okay, so it is a mode of ventilation which I no longer use, but I know there's a lot of places people use. I would say bi-level ventilation is a much better mode of ventilation to be used, because in bi-level ventilation, you are allowed to breathe on both the levels of PEEP. But all this depends on what kind of ventilators you have at your place. If you have ventilators which can only give pressure controlled ventilation with PEEP, then you have to manage with what you have. Don't try setting APRV on that. In which case, what you got to realize is, one, is your patient recruitable? Which means, are you having a disease where the lung bases are collapsed? You can recruit and you can improve ventilation. Because if you can't do that, then increasing PEEP or anything is not going to help. Then what will help you is proning your patient and starting your patient on some pulmonary vasodilators. These are the things which you should immediately go to. If that fail, if you have an ECMO center nearby, call the ECMO center. Yeah. Now, if your lungs are recruitable, then of course you have to use one of the recruitable modes of ventilation. The recruitable modes of ventilation which we have is either you go with pressure controlled ventilation and keep going up with your PEEP till you come to an optimal PEEP, okay, which means the PEEP at which you can measure the compliance is at the best. Or you can put APRV. Okay, APRV, we use APRV quite a lot because I'm a fan of APRV. I find that if you use it early and if you use it right, it really helps your patient. So for me, it is not like I go on bi-level and then go on to APRV. I go to a choice of APRV as a recruitable mode of ventilation in the first instance. And there's quite a lot of times you can actually prone the patient and use APRV on these patients, and they do have good results with that. So in answer to this question is that if you actually have a pneumothorax and a pneumomediastinum, don't be scared. You are going to see at least 1 in 5 of your ventilated patients develop some kind of pneumomediastinum. Okay, there's nothing to be surprised about. There's plenty of case reports which say that this happened. So you have to bite the bullet. You have to put in the chest drain. You have to observe. And we have seen a lot of patients come out even though they had pneumothorax or pneumomediastinum. They have continued ventilation. Once they go on to a tracheostomy, and then you can put them on a spontaneous mode of ventilation, which would be either if you're on APRV, you just drop and stretch, or you put them on a pressure support ventilation. Once they go on to a spontaneous mode of ventilation, then that is a time where you actually start thinking, okay, now is it time for my chest drain to come out? And sometimes one chest drain doesn't do the trick. Sometimes you have to use multiple chest drains. You have to put the chest drain on suction. So and sometimes it just plain doesn't expand, and you have to be very, very vigilant of that. Sorry for very long answer, but it was just trying to explain this concept slightly more clearly. Anyone else want to add?
Bottom line is that if you have pneumomediastinum or you have a pneumothorax, you just put in a chest drain. Leave it. Don't be in a rush to take it out. Let the patient come down to normal FiO2s. Okay, don't rush to get X-rays and things. So just leave it, and you might need to actually use suction. I think especially if you have the pneumomediastinum for a long time, I think is a worry for most people. Like they don't see pneumomediastinum that commonly.
And it is not worrying. It's not worrying, Shiv. There is a pneumomediastinum, it exists. And in most of the cases, you get the pneumomediastinum secondary to the pneumothorax, and you will find a lot of patients develop very scary subcutaneous emphysema.
Absolutely.
We've had patients having subcutaneous emphysema almost up to the face. Just accept you are going to see that. If you are going to have a patient like that, then come out from a mode of ventilation like APRV to pressure control with low PEEP. Okay, make sure that you can minimize whatever iatrogenic damage you might be doing in that situation, and revisit, and they will get better. They will get better. So be reassured, they will get better. Just because someone's face is puffed, they're having a lot of air, the X-ray looks horrendous, don't worry about it. If the thing with COVID, what we found out, it's persistence. Most of these patients will have to be ventilated for 3 weeks, 4 weeks. They will have tracheostomies. I know Teju was mentioning something about a unit. I'm not a guy for early tracheostomies, but these patients need tracheostomies because these are not the kind of guys who are going to get out of a ventilator within a week or 10 days. Once you put the tube in, expect that tube to stay in for at least a couple of weeks. So you have to be very patient, and you have to be just very, very persistent.
Okay. So the next scenario I will actually give you, this is someone who actually I know. So this is, well, I don't know personally, but through someone. And this is a young patient in his early 40s. Patient is diabetic, but very well controlled. And he was initially, obviously COVID positive, was on, NIV, nasal oxygen, NIV, then deteriorated, got intubated, and now is quite extensive to the extent that the patient is on 100% oxygen, has been prone, and PA to FiO2 ratio is around 83 in this patient. What further can be done? Now, the thing is that I've been trying to contact the intensivist, but I'm not getting any contact with them. I mean, they have sent a message, but not got a reply. But what would be the sort of outcome in this, and how long can they persist with such a low PA2 by FiO2 ratio? 83, less than 100. So this is severe. Tej? Your mic.
So what was the FiO2 you mentioned?
Is on 100%. prone.
100% and a
Patient
PF
is
ratio
prone.
of 83 and prone.
Yeah, yeah,
So
Theodore.
I think this is just my perspective. So
Yeah,
if the patient is already prone and they're already on 100%
yeah,
FiO2, because ours is a ECMO center, we
yeah.
activate VV ECMO team and let them know so that this is the
That is,
situation.
yeah,
But in the interim, we
yeah,
also try with some pulmonary vasodilators like nitric. So
yeah,
we go up to 10 to 30 parts per million inhaled nitric, and we
mm,
try if that helps. Of
yeah,
course, I presume that this patient must be anticoagulated and they must have paralyzed as well. So that is another strategy that we
yeah,
do before proning. We
yeah,
first paralyze the patient to avoid ventilator dysynchrony. So
yeah,
if all of this has been tried, the next thing would be inhaled nitric.
yeah,
And whenever we unprone the patient, we try to take that window and do an echo to
yeah.
see if there is a cardiac component as well, to
Okay.
try to see whether if improving the cardiac contractility does any difference to the pulmonary perfusion and things
Yeah,
like that. So that is one other thing that I would think of
yeah,
at this point.
yeah. I think in India, I think nitric oxide is not that easily available or is not used. Mohan, any inputs on
So
what
I
we?
So one of the things which we did, this was one of the questions which I was asked on pulmonary vasodilators. I mean, we don't
Yeah,
use nitric oxide in UK too because it is a very temporizing method. Once you stop the nitric oxide, it's gone. Tachyphylaxis develops quite fast. The
yeah,
other thing which we commonly used are prostacyclin. So you can
yeah,
use either prostacyclin nebulizers or you can use IV prostacyclin. IV prostacyclin has the risk of actually dropping your systemic blood pressure too.
yeah,
So you have to be very careful about that. Inhaled prostacyclin, what we used was we had ultrasonic nebulizers, which you could give continuous inhaled prostacyclin with.
yeah,
Or the other thing you could do is you could even give intermittent prostacyclin. Once you give an intermittent prostacyclin, you'll
yeah,
immediately come to know if there is benefit or not. Because we've
yeah,
had patients, we've done prone and then we've given prostacyclin and immediately the FiO2 has come down. In those cases, if that happens, then we can think of other methods which you could actually use to improve. So you can then use continuous inhaled prostacyclin. So that is one thing which you can do. The
yeah,
other thing which you could do is you could, especially as Teju said, I mean, one of the things which we do when we are trying to recruit someone to recruit the lungs is make sure that they're well filled, and secondly, make sure that their RV is not dilated. Because if that happens, giving all that amount of PEEP and APRV all causes quite significant damage to your RV.
yeah,
So, but there is an agent which can be used which improves your cardiac contractility as well as your pulmonary vasodilators, which are called as inodilators. They are your phosphodiesterase inhibitors like milrinone, inoximone. So these are some things which you can use. Only thing you have to be careful about is please don't give the bolus dose. There was one time milrinone was called as the yellow poison, or who used to
yeah,
cause quite a lot of problems, and that was because of the bolus dose of milrinone. So if you actually need to use it as intermittent infusion. Well,
about
PG,
nebulizing Milrinone.
yeah, you could that has been tried in some centers. They have tried nebulizing milrinone. They have found good effect with that. If barring all that, if you want to give a pulmonary vasodilator, you've got nothing available. One of the things which is available is sildenafil or any of those analogs. I mean, usually used for long-term management of pulmonary hypertension. But
Yeah,
when you have nothing, there is no harm in trying that too.
yeah,
So there's wide variety of pulmonary vasodilators which are available. But in your case, which you were asking, Shiv, whereas
yeah,
what you got to realize is ventilated patients in COVID have a very high mortality. Yeah.
yeah,
So once you have intubated someone, the data around the world, is with mechanical ventilation, the mortality could be up to 40%.
yeah.
So you have to be prepared that every alternate patient you have who has been intubated from COVID will not survive.
That's
and
true.
and when it comes to a point where you think you have done everything, like we have talked about right from the beginning, because Teju was mentioning about ECMO, that's true. But once you're on a muscle relaxant, and if you've been ventilated for 2 or 3 days, the people from ECMO centers use one of the two scores, and I think what we use is called as the RES score for finding out whether someone will be eligible for ECMO. If you have a RES score of 3 and above, they might take the patient for ECMO. If it is below that, in centers like the UK, they will definitely not take a patient for ECMO because the mortality is quite high anyway. So even though it sounds like a very good option, the problem is all these work when you do it early. And so it is a decision which you have to take quite early on whether a patient's for ECMO or not. I would say talk to an ECMO center. If you suddenly find your patients on a oxygenation of 100%, you have tried proning them a couple of times, you have used neuromuscular blockade, within 48 hours, if you refer to them, your resp score is usually high. So the chances of the patient going for ECMO and actually getting ECMO is much higher. But at the same time, if you are on a prolonged ventilation, if your oxygen requirements are persistently 100%, then honest conversation needs to be had regarding what the prognosis is going to be in that case.
Yeah. Okay. So it's, I think, pretty late for Tej, and it's almost an hour. I think we need to keep this sweet and short, short and sweet. um, I think we can sum up few of the things we actually have discussed today. Nobody has actually posted actual.
Just one point
Yeah.
before we
Yeah.
summarize.
Yeah. Go on.
I think Mujib sir mentioned about dobutamine
Yeah.
usage.
Mhm.
And if Dheeraj sir want to just let us know about what his thoughts are on using dobutamine in these patients.
Are you talking about as an inotrope or?
No, I think a lot of people use dobutamine for right heart failure, sir.
During this time.
During this time, and if there is increased right heart pressures, their logic is that dobutamine will anyways improve in ventricular contractility, be it left and right. I don't prefer to use it because I think that it will worsen the LV oxygen demand supply ratio. But then what are your thoughts on using it for right heart failure, sir?
So very frankly, I mean, I'm not a cardiac anesthetist, but we do look at quite non-cardiac cases. Dobutamine is not my preferred choice for inotropy anyway. I think all cyclic AMP mediated inotropes have been shown to cause more damage than any benefit. Especially in right ventricular failure, if you actually see whatever the noradrenaline is supposed to be the pressor of choice, and even for left ventricular failure now, there have been papers which have compared noradrenaline with adrenaline and have shown the outcome to be better more with noradrenaline than with adrenaline. So I personally would not use it in this scenario. I mean, if you're finding that your RV is dilated, look at what your RV pressures are, and then look at what your blood pressure is. If you can do anything to improve your RV pressure perfusion, then noradrenaline would be a choice to do that. If you're thinking your RV is struggling because your pulmonary pressures are high, then what you really need to use is a pulmonary vasodilator. You need to decrease your RV afterload with a pulmonary vasodilator. In again is the case where nitric oxide or whatever we've been discussing. So that's the reason why milrinone would be quite useful, because you would probably increase the inotropy. You will actually decrease the pulmonary pressures, plus the amount of oxygen consumption, though is there, but it's not as bad as the tachycardia which can be caused by dobutamine. So this is just my personal opinion. This is what I would do.
Mohan, do you use in your ITU for these COVID patients? Your mic is off, Mohan. Mic. Yeah.
Right now we're in the pandemic explosion. I wouldn't try anything complicated on a single patient. We would try to triage the manpower resources to do as much as possible, rather than sit and brood over a patient. We are really under tremendous stress right now.
Yeah.
Maybe these kind of trials and experiments we can do when we have adequate manpower resources and there is no surge. But you can just keep going around in the hospital and try fixing as many problems as possible. There are patients in the wards also who need a little help. We are just in survival mode.
I think I loved your approach, guys. I think Mohan and Anil, where you actually have tried to simplify things, and that's what's the need of the hour is in India.
Yeah.
Where there is so. I think I like your idea of actually using clonidine in these patients. I mean, rest of things, obviously, everybody is doing, like giving nasal oxygen, high flow oxygen, CPAP or BiPAP, and like your experience shows that BiPAP probably is better tolerated. So that's pretty good. Um, I think what would be your before we end, Mohan? What would be your take-home message for rest of the guys, especially because you guys are dealing with these kind of cases day in day out now?
I just put a message in one of the WhatsApp groups last month.
Hmm.
This was for the ward guys. They were sending out messages. This patient is on 15 liters, saturating
Yeah.
80, 82, 70, all kind of weird numbers.
Yeah.
I told them there are 10 things we do in ICU. 8 of them you can do in the ward. First
Hmm.
thing is proning, second thing is proning, third thing is proning, and still eighth thing it is proning. And ninth is a ventilator, and 10th is some nutrition or something.
Yeah.
So you guys have 9 things in the ward. Please do that.
Yeah.
And encourage them to become prone commandos.
Yeah.
So and whenever they say somebody's saturation is something, they have to tell me that the patient has been prone for 4 hours.
Yeah.
They really have to do that, and that has helped. Many of the patients waiting for the ICU bed, if they have no comorbidities less than 50 years, while waiting for the ICU bed, they have recovered and gone home. It is
Yeah.
only those with comorbids, those who are uncooperative with proning,
Yeah.
they end up with a code blue and a crash.
Excellent. Excellent. I think that's the thing. I think there is a lot of panic in India about people requiring beds, and I can tell you again. I mean, a lot of you would have had that experience. Yesterday, again, one of my own relatives actually got a phone call saying, "Oh, they are saturating this much. They had COVID." I said, "Have you even proned her? Told her to go up prone?" And despite actually giving them all the leaflets and explaining how to do and things like this morning, oh, saturation has been around 80 to 9, 85 to 90. And I said, have you prone them? No. Okay. And they had oxygen cylinder and everything at home. Did you actually even try some oxygen? No. And they ultimately they took their, whatever you say, you will not be able to change some of this mindsets. They ended up taking the patient to the
I
hospital.
asked them to prone wherever they are, at home
Yeah.
or in the ambulance or waiting
Yeah.
for admission somewhere.
Yeah.
They have to prone.
Yeah. Yeah.
And usually the other thing what we learned now is usually when the patient starts to recover, we start to sit them up and mobilize them.
Yeah.
That is a mistake. They pull up the secretions and deteriorate again.
Yeah.
They need to remain in a flat position or prone
Hmm.
until maybe the 10 days or 14 days when they're really out of that COVID hypersecretion phase and alveoli getting blocked. Only then they can be mobilized.
So how
Otherwise,
do you
those whom we
how do you
sit up,
judge, sorry, how do you judge that this is the time when they're not secreting? Is it just the productiveness of the cough?
one is productiveness of the cough, and when you've seen a steady decline in the ventilatory pressures, and with your reduction in pressure support, they should not deteriorate. If they deteriorate, they go back to a supine or a prone position.
Okay, no, we were talking about patients who are now actually not ventilated at all. Who have just managed with non-invasive ventilation and then weaned off to nasal.
It is just trying to see what position they were in the last 24 hours and
Yeah.
what's happening to their oxygen requirement trends. If they're worsening, they need to get back to proning.
Yeah. Okay.
And due to shortage of time, actually, we tell them you remain prone for another week or 10 days.
Okay. Okay. Yeah. I think that's a good message. The prone. Okay.
Yeah.
And rest is nutrition and hydration. And whatever
Yeah.
they want to take kada and things like that. Because I know my relatives in Delhi, even in the hospital, they were being in kada. I said, what is this kada thing? There's some kind of a herbal stuff. So that will go on in India, and I don't think we can actually stop that kind of stuff. And
We've been
multivitamin
trying.
stuff.
We've been treating common cold with antibiotics for over a century now, or,
Yeah,
or
yeah.
from whenever we
Yeah,
found
yeah,
antibiotics.
yeah.
So I think getting away from any kind of therapy or having any drugs not given to them is going to be very, very difficult. I think that scenario is like they might just come back and say, I think I have doctors when I try to tell them saying, oh, he doesn't know what he's talking, patients in UK are different.
Yeah,
Fine, okay. If
that
that's
will
the case,
be
it's quite common. But I agree. This proning is something which is easily done, and it can actually improve your oxygenation even without having to use oxygen. And that is the message which should go out, saying that try this at home before you actually run and buy oxygen concentrators and oxygen cylinders, and definitely try that before you are going in for tocilizumab and you know other agents like remdesivir. So
yeah.
I think that's a very useful message, Mon. It's quite useful, and I think we should try to get it more. But hopefully, what we were trying to do here is not, is once the patient comes under the care of some physician in the intensive care, and there's a poor DNB resident who has to look after a patient with a ventilator and has no clue of what's going on. This was intended to help that group of patients.
So, Dheeraj, before we conclude, any messages for the guys? I'm just
No,
concerned the page has been awake for a very long
yeah.
time.
No,
Past midnight, yeah.
I think the whole purpose of starting this was to have a COVID round. I mean, I don't know. We'll discuss about the frequency. We were hoping some guys could get some cases and they could ask us some questions if they are not getting answers which they want. I know it was very short notice, but what we were very keen is that if we have some kind of discussion like this and put it on the group, maybe
Yeah.
then people might step forward and go from there. We are going to have a COVID seminar on Thursday, which we are going to not just talk about the physical aspects of what we talk, but about how to deal with these kind of situations, because ultimately we are just human beings. And this is a bad blow, because I can understand how people are feeling. Because when I went into my ITU last April, when I couldn't understand why people in front of me were dying despite me trying all my tricks with ventilator, the feeling of helplessness which I got was immense. I've never had that feeling ever in my life as an intensive care consultant. So it's important to acknowledge that too. And we are trying to find out what support we can offer, aren't we, Shiv? And then
Yeah.
maybe we can have some more choice there. So our message is very simple. Please ask us for help if you need, whatever aspect it is. If it is anything to do clinically, maybe just message one of us and get back to us, and we'll try our best to help you with this ongoing crisis. And be safe and stay strong. That's all I can say. Thank you.
Right. Thank you, Dheeraj, Anil, Mohan, Tej, and Dilip, DSP. Thank you very much, guys. And we'll see you soon. I think we need to keep this, I think all these sessions to be short and sweet. Maybe an hour should be a cleanup. And we'll see you on Thursday.
All right.
Sure, sir.
See you.
Yeah.
Bye.